Once upon a time, someone waited for life to get easier, and then one day, life killed them out of boredom and used their bones to steal someone else's coffee. And this is not a motivation for you to start a lecture. And I'm not sorry that the thumbnail was offensive, because it was meant to bring you here to make you realize that what you are paying in the cost of procrastination. So if you have to work for your dreams, right? So we were doing endocrine pathology. I will start right now, and then you have to buckle up, grab a cup of coffee, or do whatever. But I challenge you to stay until the end of this lecture. This will be just half an hour. Check your patience yourself. So we will be talking about insulin, diabetes mellitus, and parathyroid disorders. So let's begin without further delay in insulin, that is diabetes mellitus. Let's begin. So what are the acute manifestations? What is diabetes mellitus actually? It is that the reduced condition of insulin or normal condition of insulin with increased resistance of insulin receptors. That is the condition, right? So diabetes mellitus, what are the acute manifestations of diabetes mellitus? We are basically talking about type 1, and polydipsia, that is increased thirst, polyuria, increased urination, polyphagia, that is increased hunger. 3 P's are the never to be forgotten symptoms of diabetes mellitus. You have to note it down or remember it in your tip of the tongue. And weight loss, and also DKA. It is diabetic ketoacidosis and hyperosmolar hyperglycemic state type 2. These are present in type 2. DKA is present in actually type 1, and then HHS in type 2. So we will talk about this hyperglycemic emergency or diabetic emergency with management in a short duration. So rarely it can be caused by unopposed secretion of growth hormone and epinephrine, also seen in patients on glucocorticoid therapy, that is steroid diabetes, or we also call it adrenal diabetes in Cushing's syndrome. And then there are chronic complications of diabetes mellitus. They can be either non-enzymatic glycation or osmotic damage, right? Non-enzymatic glycation, it can happen in small vessel disease. It can manifest as a small vessel disease as haline arteriosclerosis that cause diabetic retinopathy, diabetic neuropathy, diabetic nephropathy, and also large vessel disease, that is in atherosclerotic cases, right? Coronary artery disease or cerebrovascular disease, peripheral vascular disease. MI is the most common cause of death in diabetic patient for this one sole reason, right? So in non-enzymatic glycation, what actually happens is that there is formation of advanced glycated end products due to increased glucose concentrations, and these advanced glycated end products are very toxic to our body, right? So another way that the increased glucose concentration degrades our body is osmotic damage by sorbitol accumulation in organs with aldose reductase, and then decrease or absent sorbitol dehydrogenase, right? So this is the pathophysiology for osmotic damage, and the manifestations are neuropathy as in motor or sensory, glove and stocking distribution. You have to remember this, glove and stocking distribution, that is the region where you wear your gloves, right? Like hands, the palms, and stocking that the females wear, the stocking until the below the knee kind of thing. So this distribution of neuropathy will be there, sensory neuropathy, and then it will present as tingling sensation, and autonomic degeneration as in GERD, gastroesophageal reflux disease, gastroparesis, that is decreased motility, and then diabetic diarrhea can occur, and also cataracts can happen due to diabetes. These are the chronic complications that we have been talking about. So let's talk about the diagnosis. How do we diagnose the case of diabetes? So there is different criteria for the different criteria for the diagnosis of diabetes, that can either be WHO criteria or ADA criteria. Basically, you have to know the differences between these two in your third year. So we are preparing step 1 right now, not step 2. So let's begin. Let's do just concise criterization or categorization. So basically, we have to check the HbA1c level, that is hemoglobin, glycated hemoglobin, and then diagnostic cutoff is greater than 6.5%. So greater than 6.5% of HbA1c indicates that there is average blood glucose over prior 3 months influenced by RBC turnover, right? So SbA1c is a very best indicator for glucose because it reflects average blood glucose over prior 3 months. Why is that? Because the lifespan of RBC is 120 days, right? So when glucose is glycated, like when glucose is glycated to the hemoglobin, like glycated hemoglobin will form. So the lifespan of glycated hemoglobin is also 3 months. So it basically reflects average blood glucose over prior 3 months, right? So greater than 6.5 percentage, and in fasting plasma glucose greater than 126 mg per deciliter, fasting for greater than 8 hours. You have to fast for greater than 8 hours to measure fasting plasma glucose. That should be greater than 126 mg per deciliter, and 2-hour oral glucose tolerance test. This is also asked as OGTT test. You cannot get confused with this, right? OGTT test, how is it done? It is done by the 2 hours after consumption of 75 gram of glucose in 300 ml of water, mixed in 300 ml of water. So if it is greater than 200 mg per deciliter, it is a like criteria matched for diabetes diagnosis. And random plasma glucose is whenever like presence of hyperglycemic symptoms is required for this, and greater than 200 mg per deciliter is the range. So let's talk about what actually happens when there is decrease in available insulin. Available insulin means the synthesis of insulin can be decreased, or there can be resistance to the insulin, right? So if there is decrease in available insulin, that is, the body does not know whether the glucose is to be increased or decreased, because there is no action of insulin, and body is trying hard and hard to get glucose sensitized by the insulin, right? So the body thinks that there is not enough glucose due to the decrease in insulin. That is why body tries to gain more amount of glucose in any ways possible, and that is why lipolysis will increase, because that will cause increase in plasma free fatty acids, increase in ketogenesis, ketonemia, ketonuria, and also this causes anion gap metabolic acidosis that is manifested as hyperventilation, increase in respiratory rate, and Kussmaul's respiration, that is, you can smell fruity smell will be there, right? And increase in ketogenesis, ketonemia, ketonuria will lead to vomiting, that is loss of water and sodium and potassium, causing hypovolemia, and that will eventually lead to circulation failure or decreased tissue perfusion. Another thing is that increase in plasma free fatty acid will then go to the gluconeogenesis process. The gluconeogenesis is actually the formation of glucose from non-carbohydrate source. You probably already know that, right? So another part is that it will increase proteolysis, that is decrease in muscle mass. So in diabetes type 1, the patient usually presents as lean and thin features, right? There is decrease in weight, there is weight loss, extremely weight loss. This thing also facilitates increase in gluconeogenesis, as I have talked earlier, because decrease in muscle mass is the degradation of protein forming amino acids, and then amino acids are again then shunted towards gluconeogenesis. And now there will be decreased tissue glucose uptake due to decrease in sensitization of GLUT4 receptors also, and then increase in glycogenolysis because the body thinks there is increased need in glucose, right? So these all causes hyperglycemia, glycosuria. So glycosuria cannot be manifested in all patients equally, because the renal threshold for glucose is different for different patients, right? So in screening of diabetes, if you do glycosuria or like urine glucose test first, you cannot exclusively say that the patient is not diabetic if you cannot find out any glucose trace in the urine, right? Because the renal threshold of glucose is different for different people. Renal threshold is the amount of glucose required to be present in the urine. That is renal threshold for glucose, right? So this causes osmotic diuresis. Osmotic diuresis will again cause loss of water, sodium, potassium, causing hypovolemia, causing circulation failure and tissue perfusion. Another path is that it will increase plasma osmolality, and that is why it will increase thirst. That is the symptoms associated with polydipsia. That is why there is polydipsia. And since you increase the thirst, there is increase in water intake. That is one reason. Another reason is there is diuresis, osmotic diuresis, right? That is causing polyuria. This is causing polydipsia, this is causing polyuria, and increase in proteolysis, decrease muscle mass, weight loss, increase in lipolysis. These all are causing increase in hunger. That is causing polyphagia. These are the three classic symptoms, and these are the reasons why they are present like that, right? So let's talk about the differences between type 1 and type 2 diabetes mellitus. This is very much important, right? And type 1 and type 2. Let's begin. So primary defect in type 1 diabetes is that the autoimmune T cell mediated destruction of beta cells, that is islet cell, right, with or without anti-glutamic acid decarboxylase, with or without insulin autoantibodies often present. So anti-GAD will be there, autoantibodies of insulin. The most common and that one antibody that you have to remember is anti-GAD, GAD, that is anti-glutamic acid decarboxylase. You have to remember this one antibody, like you must have to remember this. And then the primary defect in type 2 diabetes is that there will be resistance to the insulin due to adipokine secretions in obesity or various reasons, and that is progressive progressive pancreatic beta cell failure can also lead to type 2 diabetes. So insulin necessary in treatment? Is insulin necessary? It is always necessary, because there is absolute deficiency of insulin in type 1 diabetes, right? But it is just sometimes necessary in type 2 diabetes because there is extreme concentration of insulin due to compensation, and that will lead to decompensation. And then the age exceptions are very common in this case. They can present, like a person less than 30 years can present with type 2 diabetes, and greater than 40 years can present with type 1 diabetes. This is not a quite particular distinguishing feature. So less than 30 year, greater than 40 year. Association with obesity, there is no association in type 1 diabetes. And then there is association with type 2 diabetes, because there is a extreme association in type 2 diabetes because the obesity will increase the adipocyte formation. These adipocytes will release adipokines, right? And then toxic metabolites, and then reactive oxygen species, and all other things that cause eventual beta cell failure, right? That are the pathogenesis for type 2 diabetes mellitus. So obesity is very frequently related with type 2 diabetes. Genetic predisposition, there is relatively weak, that is 50% concordance in identical twins and polygenic, right? So there is relatively strong 90% concordance in identical twins, and this is also polygenic. Association with HLA system, this is what you have to remember right here. So there is association with HLA system in type 1 diabetes, that is HLA DR4 and DR3. 4 minus 3 is type 1. That is how you can remember. HLA DR4, DR3. So 4 minus 3 equals type 1. So there is no association in type 2 diabetes. Glucose intolerance, there is severe glucose intolerance, there is mild to moderate, and insulin sensitivity is high, but there is no insulin, no secretion of insulin. Insulin sensitivity is low because there is already resistance developed. And then ketoacidosis is very common in type 1 diabetes. It is rare, and beta cell numbers in the islets will be decreased. It is variable with amyloid deposits, right? And serum insulin levels will be decreased in this case. And then it will be increased initially but decreased in advanced disease. Why it will decrease in advanced disease? Because there will be progressive beta cell failure, and since there is no beta cell, it can cause it can obviously lead to decrease in insulin, right? Because beta cell is what secretes insulin. The classic symptoms are common. They are present sometimes in this case, and histology is islet leukocytic infiltrate can be there. Islet amyloid polypeptide deposits are there in this case. So polydipsia, polyuria, polyphagia, and weight loss, these are the classic symptoms. So let's talk about hyperglycemic emergencies. These are very important for you in step 1 and also in step 2. This is very important. So you have to remember this at any cost. You have to understand the fundamentals of this. So let's talk about diabetic ketoacidosis first, and then HSS, right? So pathogenesis of diabetic ketoacidosis is that there will be insulin non-compliance or increased requirements due to stress, as in infection cases, right? Increased stress as in infection cases, and that will lead to lipolysis and oxidation of free fatty acids. Oxidation of free fatty acids will lead to reactive oxygen species also, and peroxidase formation also, that will lead to increase in ketone bodies, that is beta hydroxybutyrate. There are two ketone bodies, actually three ketone bodies in our body actually. So acetone, acetoacetate, and beta hydroxybutyrate. These are three ketone bodies. And then there will be increase in ketone bodies, and comparatively there will be increase in beta hydroxybutyrate bodies, ketone bodies, than acetoacetate. Then insulin deficient ketones are present obviously. And signs and symptoms: DKA, that is diabetic ketoacidosis, is deadly, that is delirium is present or psychosis. And K is Kussmaul's breathing, Kussmaul's respiration, that is rapid deep breathing with acetone fluidy smell. And then abdominal pain, nausea, vomiting, and then dehydration will be there. So fruity breath order due to exhaled acetone, I have talked about it. So DKA is deadly, that is the classic symptom. D for delirium, K for Kussmaul's respiration, A for abdominal pain, nausea, and vomiting, and another D for dehydration. These are the classic symptoms, right? The lab findings are there will be hyperglycemia, increase in hydrogen ions that causes metabolic acidosis actually, lactic acidosis, and increase in decrease in bicarbonate that will lead to increase in anion gap metabolic acidosis, and increase in urine or blood ketone levels because there is high ketonemia and ketonuria due to increase in glucose, and that will cause leukocytosis. There will be normal or increased serum potassium levels but depleted intracellular potassium due to transcellular shift from decreased insulin and acidosis. Osmotic diuresis will cause increase in potassium loss in urine that causes total body potassium depletion. So what are the signs and symptoms here? There will be hypokalemia also, right? There will be hypokalemia. There will be, right, the hypokalemia has a different reasons for that. There is osmotic diuresis, one of them is there, that, and then another is there will be depleted intracellular potassium due to transcellular shift from decreased insulin and acidosis. So there will be metabolic acidosis, that is also HAGMA, that is high anion gap metabolic acidosis, and then hypokalemia, leukocytosis, ketonemia, ketonuria. These are the lab findings. The complications are life-threatening, mucormycosis, that is the classic opportunistic feature, infection, cerebral edema can be there, cardiac arrhythmias can be there. So what are the treatment? Treatment is IV fluids to counteract the dehydration, IV insulin to treat the hyperglycemia, and potassium to replete intracellular stores, and glucose may be required to prevent hypoglycemia from insulin therapy, right? So the overdose of insulin can cause hypoglycemia. So that is another side effect for insulin. The insulin is treated for hyperglycemia, but the side effect of insulin is hypoglycemia. So the other clinical manifestation, diabetic emergency, that we have to read, that we have to understand is hyperosmolar hyperglycemic state. So what is that actually? Let's talk about that, okay? So there will be profound hyperglycemia, and that will cause excessive osmotic diuresis, and that will cause dehydration and increase in serum osmolality, that is HSS. Classically seen in older patients with type 2 diabetes mellitus and limited ability to drink. Insulin will be present, and ketones are deficient. So this is the feature. Pathophysiology is almost same, but the distinguishing feature right here is insulin will be deficient in decay but present in HSS, and then ketones will be present in decay but ketones will be deficient in HSS. Obviously this is not this symbol. This is very complicated. You will study that in step 2. But for now, this is enough. So thirst, polyuria, lethargy, focal neurologic deficits, and seizures. These are classic signs and symptoms. And then hyperglycemia, often greater than 600 mg per deciliter, increase in serum osmolality of greater than 320 milliosmol per kg. Normal pH, there will be no acidosis. Also, that is also another feature. And normal or increased serum potassium, that is decreased intracellular potassium. This is the features. You have to remember this, right? So complications is that it can progress to coma and death if it is untreated. So these are the complications. And hypoglycemia and diabetes mellitus. Let's talk about that. Why hypoglycemia occurs? Obviously due to insulin overdose or overtreated insulin. Usually occurs in patients treated with insulin or insulin secretagogues, that is oral antidiabetics, right? So sulfonylurea and then meglitinates in the setting of high dose treatment, inadequate food intake, and also exercise. So these are neurogenic and neuroglycopenic syndromes will be there. Neurogenic and neuroglycopenic. What are the differences? Neurogenic is due to autonomic symptoms, that is diaphoresis, increased sweating. Actually, what happens is neuroglycopenic symptoms appear first, that is altered mental status, seizures, death due to insufficient glucose in the CNS. Since there will be insufficient glucose in the CNS, then that will release, that will force the body to release adrenaline, norepinephrine, and that cause autonomic symptoms like diaphoresis, increased sweating, increased heartbeat, tremors, anxiety, hunger. That is why it causes. So it allow perception of decreased glucose, that is hypoglycemia. Awareness will be there in neurogenic symptoms. And then neuroglycopenic, it may occur in the absence of preceding neurogenic symptoms in patients with attenuated autonomic response, that is beta blocker use. Actually, this actually happens first due to stress and then this, right? So if there is a patient who who is in cardiac diseases, or maybe who continuously uses beta blocker, so this autonomic response will be masked, right? So hypoglycemia unawareness will be there due to these reasons. So treatment is simple carbohydrates, that is glucose tablets, fruit juice, IM glucagon, IV dextrose. You don't need to remember the doses right now. You will be studying that in step 2. So that is the treatment, right? This is diabetes. It is enough for you today, because the more you study in a single session, the more will be like the less will be the retention rate. You can revise this lecture right now that you have made in the notes. I will be continuing this parathyroid disorder, just these 2 pages, and then Cushing's disease in another lecture, right? So stay with me, subscribe if you haven't already, and we will cross this USMLE and you will get whatever residency dream you have seen. You will get that, and no procrastination can afford to get that away from you. Thank you.